Welcome to the training Autism Spectrum Disorder. Your presenter is LORourke. Before we begin, we need to have a disclaimer. All of the research and information about autism spectrum disorders is updating and changing rapidly. Therefore, the information that's referenced and represented in this presentation is accurate and current as of November 2015. Our agenda today will be to talk about the history of autism spectrum disorder, diagnostic criteria, the prevalence of autism spectrum disorder, causes and risk factors, diagnosis, effective treatments for autism spectrum disorder, prognosis, and additional resources. First, we're going to talk about the history of autism spectrum disorder. The word autism was coined in 1900. Autism comes from the Greek word autos, which means self, which is where that word came from. Then in 1908, Eugene LORourke first used the term autism to describe schizophrenia symptoms. Later in 1943, a man named Leo Kanner used autism to describe withdrawn behavior of several of his patients. At the same time, in 1944, Hans Asperger studied 4 boys and described a milder form of symptoms, similar to Leo Kanner's. Then in 1952, the first diagnostic and statistical manual was written and noted autistic-like symptoms under childhood schizophrenia. It wasn't until 1964 that autism hit the news again, where Bernard Rimland theorized that autism could be caused by biological factors. In 1967, Brutal Bettelheim claimed that autism was caused by refrigerator mothers. This was later found to be false. In 1968, the DSM was revised and updated to version 2, which classified autism under the diagnosis of schizophrenia. In 1971, the Journal of Autism and Developmental Disorders was established and was the first journal to address autism specifically. In 1972, treatments for autism started to begin to occur. They included LSD and electroshock therapy. 1977 was when they started twin studies, which showed that autism is largely caused by genetics and biological differences in brain development. And then in 1980, the DSM-3 was classified infantile autism as its own category when they updated it. In 1981, Ivar Lovaas was a behaviorist who showed successful treatments for autism using applied behavior analysis. Then in 1987, the DSM was revised and replaced infantile autism with autism disorder and included its first diagnostic criteria checklist. In 1988, the movie Rain Man brought autism to the main screen and released the movie. This is when public awareness began to increase about autism. In 1994, the 4th edition of the DSM was created, and several subtypes were added to the autism spectrum. Then in 1998, a British scientist claimed that MMR vaccine was linked to autism. This paper was discredited and fully retracted in 2010, and all of the other authors that were listed in the study retracted all of their names from the article prior to that. In 2000, thimerosal was removed from vaccines because of fear that mercury could cause autism, although there was no evidence of this. In 2001, the National Institute of Health estimated that autism affected 1 in 250 children. In 2004, the Institute of Medicine found no credible evidence of a link between thimerosal and autism. In 2007, the Center for Disease Control and Prevention, the CDC, reported that autism affects 1 in 150 children. In 2009, they reduced that to 1 in 110 children, and in 2011, 1 in 68 children, and most recently in 2015, 1 in 45 children. In 2013, the DSM-5 eliminated the subtypes for autism spectrum disorder, and individuals are now diagnosed with autism spectrum disorder alone, with a corresponding level of severity. We now consider autism spectrum disorder to be just like a spectrum, whereas each person's fingerprint is all different from one another, so is autism. There are very broad ranges of characteristics and subtypes that no one individual with autism tends to look the same as anyone else. People with autism spectrum disorder tend to have communication deficits, such as responding inappropriately in conversations, misreading nonverbal interactions, or having difficulty building friendships appropriate to their age. In addition, people with autism spectrum disorder may be overly dependent on routines, highly sensitive to changes in their environment, or intensely focused on inappropriate items. Again, the symptoms of people with ASD will fall on a continuum or a spectrum, with some individuals showing mild symptoms and others having much more severe symptoms. This spectrum will allow clinicians to account for the variations in symptoms and behaviors from person to person. When we look at the diagnostic criteria from the DSM-5, we see that all of the following 5 criteria have to be met for a diagnosis to be made. And the criteria are as follows. First, deficits must be evident in communication and social interaction. Second, restrictive and repetitive behaviors should manifest in at least 2 different ways. The individual must show symptoms from early childhood. Symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. And that just means that they have to significantly interfere with the individual being able to perform their life requirements. And finally, the disturbances can't be better explained by intellectual disability or a global developmental disability. However, it should be noted that somebody with autism spectrum disorder can also have an intellectual disability as a secondary diagnosis. And these criteria should be considered when looking at social communication when the individual is performing below expected general developmental levels. When we look at criterion A, which is persistent deficits in social communication and social interaction across multiple contexts, we're going to look for the following 3 areas. First, a deficit in social emotional reciprocity, for example, ranging from a social approach that's not typical of your peers, or a failure to have normal back and forth conversation, reduced sharing of interests, emotions, or affect, and a failure to initiate or respond to social interactions. Second, we may see deficits in nonverbal communication behaviors that are needed for social interaction. For example, poorly integrated verbal and nonverbal communication, abnormalities in eye contact and body language, or deficits in understanding and using gestures, and possibly a complete lack of facial expressions or nonverbal communication. Third, we'll see deficits in developing, maintaining, and understanding relationships that may range from difficulties adjusting behavior to suit various different social contexts, or difficulties sharing imaginative play or making friends, and possibly a complete absence of interest in peers. When we look closely at criterion B, restricted repetitive patterns of behavior, interests, or activities, we have to see 2 of the following. And we may need to see these in a representation of history, for example, when we do interviews, or we can see these behaviors currently or in real time. And again, we need to have 2 of the following 4 criteria in order to meet criterion B for diagnosis of autism spectrum disorder. That first criteria would be stereotyped or repetitive motor movements, use of objects, or speech. So examples of this might be simple motor stereotypies such as flapping hands or rocking, lining up toys, flipping objects, echolalia, which is to repeat back something that you hear, or different idiosyncratic phrases. The second criteria is the insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior. For example, we may see extreme distress when very small changes occur, difficulties with transitions from one environment or one task to another, rigid thinking patterns, greeting rituals, or a need to take the same route or eat the same food every day. And these are just examples. The third criterion that must be met of at least 2 of category B would be highly restricted, fixated interests that are abnormal in intensity or focus. For example, we might see a strong attachment to an object or a preoccupation with the same subject or an object, excessively circumscribed or perseverative interests. So maybe we only have one specific interest and that's all we want to talk about and that's all we want to focus on. We also might see, for the 4th area, hyper, which is over, or hypo, under, reactivity to sensory input, or unusual interests in sensory aspects of the environment. For example, we might notice that this individual is overly sensitive or undersensitive to pain or extreme temperatures. Or we may see adverse response to specific sounds or textures, excessive smelling or touching of objects, or a visual fascination with lights or movement. When we look at the diagnostic criteria, a severity level is assigned in both social communication and restricted repetitive behaviors to identify the overall severity level for autism spectrum disorder. A level 3 severity level would require very substantial support. And these are the individuals that are going to need a lot of support to be able to participate in their lives. A level 2 severity is requiring substantial support, and a level 1 severity is requiring support. When we look at these different severity levels, let's look at them based on specifically what it would look like for social communication and restricted repetitive behaviors. For a level 3 severity, which is requiring very substantial support, severe deficits in verbal and nonverbal social communication skills are going to cause severe impairments in functioning, very limited initiation of social interactions, and minimal response to social overtures from others. A level 3 restricted repetitive behaviors may show inflexibility of behavior, extreme difficulty coping with change, or other restricted repetitive behaviors that markedly interfere with functioning in all spheres of life. There may also be great distress or difficulty changing focus or action with individuals with a level 3 severity. Individuals with a level 2 severity may show social communication deficits in verbal and nonverbal social communication skills, social impairments apparent even when there are supports in place, limited initiation of social interactions, and a reduced or abnormal response to social overtures from others. You will also see inflexibility of behavior, difficulty coping with change, or other restricted repetitive behaviors that appear frequently enough that they're obvious to the casual observer and that they interfere with functioning in a variety of contexts and settings. You may also see distress and/or difficulty changing focus or action. A level 1 severity would require support, and regarding social communication, if there weren't supports in place, we would notice deficits in social communication. We would also see difficulty initiating social interactions and clear examples of atypical or unsuccessful responses to social overtures from others. Individuals may appear to have decreased interest in social interactions. For restricted and repetitive behaviors, for a level 1 severity, you may see inflexibility of the behavior that causes significant interference with functioning in one or more contexts, difficulty switching between activities, and problems organizing or planning that hamper an individual's independence. When we look at prevalence rates of autism spectrum disorder, the estimates have increased drastically over the past 30 years. We do know that autism spectrum disorder is reported to occur in all racial, ethnic, and socioeconomic groups. ASD is also almost 5 times more common among boys than in girls. There's disagreement by the experts about whether the true prevalence of autism spectrum disorder is increasing. It may be that diagnostic criteria has changed and developed over time. There's also been an increased awareness of autism spectrum disorder, which has prompted a lot more individuals to seek a diagnosis that didn't previously seek one. We've improved our early detection and early intervention of more subtle symptoms, and studies regarding the prevalence have also varied depending on when and where they were conducted and what the criteria was for determining autism spectrum disorder. And therefore, we look at autism spectrum disorder oftentimes as a puzzle. And the puzzle piece is a symbol that's represented autism spectrum disorder, which has grown over time. Oftentimes, advocates or individuals that support autism spectrum disorder will use a puzzle piece to represent the desire to fit all of the pieces together. Some self-advocates have recently spoken out against the puzzle piece symbol, noting they don't need to be put together, but they are already whole individuals, and therefore some sensitivity should be used when using this symbol. But despite this, the puzzle piece does continue to remain a strong representation symbol in the autism community. Now we're going to look at causes and risk factors for autism spectrum disorder. At this point, there is no single cause that's been identified for autism spectrum disorder. There have been gene studies that have specifically identified genes and chromosomes that have associations with ASD. And there is clearly a genetic link to autism spectrum disorder. Other research continues to explore possible links to environmental triggers such as viral infections, complications during pregnancy, and pollutants. And when we look at that component, the research currently is looking at potential triggers that set off a genetic change in an individual or a brain change in an individual that may be triggered by the environment in some way. There is no link between vaccines and autism spectrum disorder. When we look at twin studies, we see that identical twins will have a 36 to a 95% chance that an autism diagnosis of one twin will also result in an autism diagnosis in the identical twin. Non-identical twin studies have shown a prevalence of only 0 to 31%. So there's clearly a genetic link with autism. Parents with a child with autism spectrum disorder are 2 to 18% more likely to have a second child with autism spectrum disorder. ASD is more common for children of older parents and has a high rate of comorbidity with other developmental, neurological, psychiatric, genetic, and chromosomal diagnoses. A small percentage of children born prematurely or with low birth weight are also at greater risk of having autism spectrum disorder. When somebody's looking for a diagnosis of autism spectrum disorder, testing of children is generally accepted as reliable by the time the child is 2 years of age. However, some studies have shown that children as young as 12 to 18 months can still be accurately diagnosed. Some screenings that are available to diagnose autism spectrum disorder include the CHAT, the MCHAT, the STAT, the SCQ, the CSBS, the ASSQ, the ASAS, and the CAST. A formal diagnostic evaluation should occur if a screening notes that risk factors indicate that there may be a diagnosis of autism spectrum disorder. Different diagnostic tools that are currently being used include the ADI revised, the ADOS, the CARS, and the GARS-2. There is not currently any medical tests that can diagnose autism spectrum disorder. The diagnosis includes subjective criteria based on direct observation, interviews, records review, and personal family history. However, there are some genetic tests that can be done to identify certain genes that may be involved in autism, but a subjective interview and diagnostic should also be used. When we look at treatments for autism spectrum disorder, the following treatments have shown to be established and effective treatments. And this information comes from the National Autism Center, which created an independent review of all of the research that indicated a treatment for autism and looked at the criteria for the studies and whether the studies showed that they were effective in alleviating the symptoms of autism spectrum disorder. And that's how these results came out. If you're looking for more information about the details of that study, the link is at the bottom of your screen, and it's highly recommended that you look at and download the National Autism Center Standards Project information. We're going to go into each of these treatments in more depth in the following screens. Behavior interventions are geared towards changing what occurs before or after a particular behavior to increase or decrease that specific behavior as desired. We can either increase the success of skills we'd like to see more of, or we can decrease the success of challenging or problem behaviors that we'd like to see reduced. Examples of behavior interventions might include shaping, reinforcement schedules, chaining, prompting, modeling, extinction, and repeated practice. Cognitive behavioral interventions have also been shown to be effective for treating autism spectrum disorders. These treatments include teaching the individual how to identify and describe emotions, how to identify physical responses to emotion, and identifying others around them who have similar challenges. The idea with cognitive behavioral interventions is to help change the thinking and to avoid all or nothing behavioral patterns, and to understand that there are different ways that you can manage your thinking and manage your behaviors. Another tool is to develop anxiety and stress scales, such as a ladder or a thermometer or a volume control, for example, that can rate a certain level of a behavior or a level of your stress or anxiety, and corresponding ways that you can address that level. Homework assignments are often used in cognitive behavioral interventions to work on skills in the home, community, and the school. and typically require some sort of self-monitoring component. Parent sessions are also used in cognitive behavior interventions. When we look at comprehensive behavioral treatments for young children that have shown to be effective, they're looking at intensive services, which is often 25 to 40 hours per week of intensive behavioral treatment for 2 to 3 years. This is where database decisions are made regarding the target skills that address the core symptoms of autism spectrum disorder. Some interventions that are common in a comprehensive behavioral treatment model are discrete trial training, errorless learning or errorless teaching, behavioral momentum, shaping, modeling, and other strategies that have shown to be effective as part of applied behavior analysis. Language training is another effective treatment for individuals with autism spectrum disorder. This is where we may model words or verbalizations to the individual, encouraging imitation of language, prompting using verbal, visual, gestural cues, cue, pause, point language training, using music as part of language training, and reinforcing the individual to use those targeted language goals. Parent training has shown to be effective, and some formats could include group training, a support group format, or parent training manual. Common parent training topics include toilet training, encouraging language and social skills, sleep routines, and developing effective leisure and play activities. However, this is not an extensive list. Different areas of modeling that can be effective in treating the symptoms of autism spectrum disorder include live modeling and video modeling. Live modeling is where we would teach the parent, specifically outline skills, and also have corresponding written directions on how to perform that skill. Then we will make sure everyone on the team is teaching that skill in the same way. And we're going to get the individual's attention first before we try to teach that skill and model that skill. And then eventually, as they're able to imitate the skill, then we would plan to fade or reduce the amount of modeling that we would need to use and encourage that child to independently display that target skill. Video modeling is where we would pre-record a session that demonstrates that target skill. We'll want to make sure that that individual is paying attention to the video, and then we're going to point out important components of the video during parent training, and that's the way that the individual can imitate the video to learn the new skill. A peer training package uses same-aged, similar skill level children to teach skills. We're going to want to find peers who are able to follow directions, have some of the social skills we're looking at teaching our individual with autism spectrum disorders, and peers who are also regularly available. It's best to incorporate interests and activity preferences of both and all of the peers that are involved in the peer training, and to teach the peer how to gain the individual's attention, guide sharing, providing help, modeling play skills, and organizing activities so that the individual is successful. After the peer training, we're going to encourage the peer to practice and use those skills in multiple environments with multiple peers. Scripting is when we use behavioral interventions along with a guide that teaches skills related to initiating or responding to different situations. A prerequisite is that the individual would have to be able to read or follow along with a picture book or a similar structure. And then once we have that script available and have practiced it and the individual is able to use that visual script, then we're going to fade that out once they become familiar with that new routine or skill or behavior. Social skills is when we teach the individual one-on-one with a peer or in a group how they would interpret and respond to different facial expressions, body language, turn-taking, joint attention, or problem-solving skills. Story-based interventions are written descriptions of a social situation or other unfamiliar activity. Story-based interventions may include specific behaviors for the individual to perform in a given situation, what to expect, and likely outcomes of a particular behavior, and also the consequences for that behavior that may occur. The language of the story is written in the first person, or I language, and often describes who, what, when, where, and why questions and answers it for the individual. Discussion and comprehension questions should also occur after the story so that the individual understands what was read to them. And pictures are often used in story-based interventions to help with understanding. Natural teaching strategies are when we observe that child to find out what they are attracted to or naturally drawn to. And then we're going to use those natural materials typical in that environment and teach skills in a variety of environments with multiple people and various materials. We're also going to use natural consequences for behavior. So for example, we wouldn't use food during playtimes because that's not a natural time where you would be eating food. And therefore we'd use food during snack time and toys during playtime. We're also going to provide some loosely structured teaching opportunities based on that child's interest on that day. Pivotal response training is an intervention that's shown to support teaching skills and alleviating the symptoms of autism spectrum disorder. This is where we would teach the child to respond to various natural opportunities and increase their independence. This program also focuses on increasing choices, and the target skills are motivation, self-initiation, self-management, and responding to various prompts or cues in the environment. Self-management skills have also been shown to be effective. This is where we would teach the individual a self-awareness of their own behaviors, teaching self-monitoring, teaching self-management, or what to do to stay calm or what to do to stay appropriate. We'll also teach the individual how to get what they need appropriately, self-management and self-monitoring to measure your own performance, and provide accountability for your own behavior. Schedules can be used for any activity at different times. They can be written, typed, drawn, picture cues, or object schedules. Schedules are used to teach a first-next concept, and they follow, often it's effective to follow a non-preferred activity with a preferred activity, and then to rotate that preferred and non-preferred activities so that an individual gets naturally reinforced by their schedule and by their environment. It's almost like a work-break system. So when we're looking at how to follow a schedule, first we're going to arrange the schedule prior to starting that activity. Then we're going to introduce that activity to the individual using the schedule. We'd point and indicate that item on the schedule. And then once that activity is done, we're going to have some way to indicate that that area or that activity is over and we're moving on to the next activity. So for example, you could take the picture off of the schedule, you could cross it out, or you could put objects in a done or a finished bin. Other treatments that have had some research or some ideas about treating autism have shown to be less successful, or we don't have enough information yet. So when we look at interventions that have emerging levels of evidence, there's at least one study or more that shows effectiveness in the intervention, but we don't have enough research to say that it will be effective across time and across multiple environments, and we need more research. These interventions would include augmentative and alternative communication devices, using developmental relationship-based treatment, exercise, exposure packages, functional communication training, imitation-based interventions, initiation training, language training, specifically in the production of language and comprehension or understanding of language, massage therapy, multi-component packages, music therapy, picture exchange communication system, or PECS, reductive packages, sign language instruction, social communication intervention, structured teaching, technology-based interventions, and theory of mind training. Again, if you're looking for more information about these interventions, you can go to the link for the National Autism Center, and they will show you the Standards Project Phase 2, where this information came from. Interventions that have little or no evidence in scientific literature about the effectiveness and are therefore unestablished levels of evidence that are not recommended at this time for all individuals with autism to alleviate symptoms include animal-assisted therapy, auditory integration training, concept mapping, DIR or floor time, facilitated communication, gluten-free or casein-free diets, movement-based interventions, sense theater intervention, sensory intervention packages, shock therapy, social behavioral learning strategies, social cognitive intervention, and social thinking intervention. When we look at the future of individuals who are diagnosed with autism and their prognosis, what we've seen is that early intervention has shown to be the most effective in improving or alleviating the symptoms of autism spectrum disorder. For many children, autism symptoms improve with age and with effective treatments. Some children grow to live typical lives and are undiscernible from their same-aged peers. Some children also will later develop epilepsy. During adolescence, depression and behavioral challenges can occur, and individuals with ASD have a higher risk for these. And many individuals with ASD will go on to live productive and happy lives, often with some supports in place. The following is a list of resources that you can go to learn more about different interventions and different supports and resources for autism spectrum disorder.